A very good evening to all of you. I am Dr. Navjeet Malik, an assistant professor in the Department of Hematology in PGI, and it is my pleasure to welcome you all to today's masterclass of hematology, organized under the aegis of the Indian Society of Hematology and Blood Transfusion. The topic for today is approach to bleeding disorders. It is my privilege to introduce today's speaker, Professor Jasmina Ahluwalia, who is a professor in the Department of Hematology, PGI Chandigarh. Professor Ahluwalia is a renowned hematopathologist and an expert in the field of bleeding and thrombotic disorders. But on top of that, I can personally vouch for the fact that she's an excellent teacher with years of teaching experience. So let's get ready to clear our concepts on how to approach a patient with bleeding disorders. Before we begin, let me just remind the attendees that if they have any questions, you can please type the questions on the chat box and they can be taken up at the end of the talk. So over to you, ma'am.
Thanks a lot, Navjeet. Thank you for your patience, and thank you to the Indian Society of Hematology and Blood Transfusion for this opportunity to be speaking to you on the approach to bleeding disorders. So let's begin with the basics. We all know that balanced hemostasis is very important because it prevents us from bleeding whenever there's an injury to a vessel wall. And this, once the bleeding occurs, a clot is formed, and eventually this clot has to dissolve so that the blood flow can be resumed. Balanced hemostasis thus is a result of a concerted action of the vessel wall, platelets, and coagulation factors. Initially, there's vascular constriction at the site of injury. Then the platelets come and adhere to the vessel wall using their receptors and getting in touch with the collagen and using von Willebrand factor, which is a circulating plasma factor. Eventually, thrombin is generated and the platelets are activated, and the coagulation factors then get activated in a sequential fashion and accumulate at the site of injury, forming a strong platelet plug, which is cemented by fibrin. Now, if there's any defect in any of these components, there can be either bleeding or thrombosis, both of which are not good for us. Abnormal bleeding, we must remember, may be the result of acquired or inherited defects, and clinical patterns of various types of bleeding disorders may resemble one another. So just by a clinical history, it is not possible to reach a diagnosis of what the bleeding disorder may be. The tests for diagnosing bleeding disorders are also currently far from perfect because they do not mimic the in vivo situation. We have actually generated tests to sort of identify bleeding disorders, but these may not mimic the in vivo situation at all. And all of us need to remember that there is now an improvement in therapeutic options for various bleeding disorders, which makes it important that we update and expand our diagnostic tests. Oops. So what is the need for coagulation testing? 20% of the general population may report with a bleeding symptom at some time in their life. So this becomes a pretty common problem. Now, patients who have bleeding will need treatment, but normal patients who are bleeding at that particular instant may need treatment, but they should not be exposed to unnecessary treatment also. So it's important to decide whom we have to test and work up further. And anytime when we do testing, we need to answer these questions. Why is my patient bleeding? Will my patient bleed in response to trauma or surgery or childbirth? That is a hemostatic challenge. Will there be any other family member who is at risk for bleeding? So do I need to test for that? And once we start treatment, is my patient adequately treated? So here coagulation testing will be needed to monitor therapy. So these are the situations where testing will be really required in patients who have significant bleeding, in patients who have a family history of bleeding, in a case of a preoperative screen before a surgical procedure or a small biopsy. Even then, if a person has been found to have an abnormal test, as a follow-up of that, there may be sequential testing required, and for monitoring patients on anticoagulants. So what is significant bleeding then? Who should we say has significant bleeding? This would be an individual who has had repeated episodes of bleeding, bleeding from multiple sites, bleeding which is serious enough to require transfusion support, and somebody who has a positive family history. Now, we can also look at it in this way, that a normal person may not bleed in response to a certain degree of trauma or a surgical stress, but anybody who bleeds far in excess of what is that for normal should be taken to be as significant bleeding. Okay, so history taking forms a very important part of the approach to a bleeding disorder. And this is the first part where the clinician encounters the bleeding patient. So it's very important to ask whether the patient has spontaneous bleeding or bleeding with relation to trauma. Spontaneous bleeding is usually always significant and needs to be investigated further. The next thing to know is what are the site of bleeds. In women, menorrhagia is a very common presentation. In children, epistaxis may be a very common presentation. Umbilical stump bleeding is seen virtually in neonates. And gum bleeds, hematuria, hemarthrosis, intracranial hemorrhage, these can present at any age. The next thing we need to see is that at what age were the bleeds first noticed? If there was a bleed in a neonate or an infant or a child, there is a likelihood that we are looking at an inherited bleeding disorder. Whereas a bleed in an adult or an elderly patient may be due to an acquired cause. We must remember, however, that mild inherited disorders may sometimes present late and may go undetected in early life. I cannot emphasize the importance of asking for existing comorbidities. There is no, this thing must be really got out in the history, whether the patient has any liver disease or a renal disease or an underlying malignancy or a metabolic disorder or hypothyroidism, because these may cause acquired bleeding disorders and there is no need to do very extensive testing in these individuals. So this history has to be gone into, testing has to be done to confirm that these things are not present before we work up for an inherited bleeding disorder. History of drug intake is very important, especially non-steroidal anti-inflammatory drugs, aspirin, and some antibiotics, because these may help in unmasking a mild bleeding disorder. Family history is very important. The presence of a family history usually suggests an inherited disorder. Autosomal dominant disorders are easy to pick up. There will be vertical transmission in the parents and in the grandparents and in the children. Now, type 1 von Willebrand disease forms a very standard example of an autosomal dominant disorder, but it comes with a caveat that it may have incomplete penetrance. So just by being an autosomal disorder doesn't mean that it will always show up in the next generation. We must remember this. If there is bleeding in siblings, but not in the parents, and autosomal recessive inheritance can be suspected. And if it's the males who are affected, then we are looking at X-linked disorders. But sometimes we must remember that carriers of X-linked disorders may also have heavy bleeding. This is true for hemophilia A and hemophilia B. Now, we need to know the history of what hemostatic measures were taken and in the previous episodes of bleeding, if they were, because this will help guide the treatment further. And it also gives us a clue of how severe the bleeding disorder is, how much intervention was required. Sometimes symptomatology or history unrelated to the bleeding disorder may be helpful. For instance, in factor 13 deficiency or afibrinogenemia, there may be recurrent abortions and poor wound healing. And we need to specifically ask for this. Before we start lab testing, it's also important to know when was the last transfusion or replacement therapy given. Because we would like to test the patient at when the patient's own baseline coagulation factor levels are there, rather than the transfused factor present in circulation. So we need to know that the timing of the last transfusion was at least 7 to 10 days prior to when we decide to sample. And once we decide to sample and we are planning to do the test, we must know when that sample was collected, whether it is a fresh sample or an old sample, because that may affect our test results. Now, coming to the nature of bleeds, these may help us to decide what kind of testing we need to do. Mucocutaneous bleeds are usually a sign of a primary hemostatic defect involving the blood vessels, the platelets, or the von Willebrand factor, whereas deep muscle bleeds and joint bleeds usually indicate a defect in the coagulation factors and secondary hemostasis. A single site of bleeding, if present, it's imperative that a local examination be done to exclude a likely anatomic cause, and this is especially true for epistaxis and menorrhagia. If there is menorrhagia as the presentation, then hormonal workup also needs to be done to exclude those causes before we undertake extensive coagulation testing. Do not forget that some psychiatric conditions may be associated with a tendency to self-harm and produce a bleeding to attract attention towards themselves. Similarly, child abuse, if there is a non-expected kind of pattern of bruising, then this needs to be suspected. Homicidal and suicidal intake of anticoagulants may also occur in some situations. In neonates and infants, it's important to ask if vitamin K was given after birth, because this small history would go a long way in deciding what might be the reason for bleeding. So bleeding history when the patient gives may be very variable. One person may think that a nasal bleed is a very serious thing and may give it very much importance and say he's a heavy bleeder. Whereas to another person, that nasal bleed may just be a mild, common thing to occur, and he may not give it any importance. So to make the assessment of bleeding a little more objective, there are tools called the bleeding assessment tools, which are nothing but questionnaires regarding the symptoms of bleeding and the severity of bleeding and the treatment required for them. And a score is assigned to each category of bleeds and the severity. So based on the scores, one can decide whether the individual has a serious bleeding disorder which needs further investigation or not. These bleeding assessment tools can be targeted towards certain diseases, say for instance platelet disorders or von Willebrand disease, or maybe even generalized for all kinds of bleeding disorders. And there are a variety of them available over a period of time. One of the common ones that is in use is the abbreviated ISTH bleeding assessment tool. And this has the symptoms shown on the left side and the score shown on the heading. And as you can see, if there is no bleeding or trivial bleeding, the score is 0. If the bleeding is severe enough just to cause a consultation, then the score is 2. And if any transfusion therapy is required, then the patient gets a high score. So based on the scores, one can decide whether there is a significant bleeding disorder or not and investigate them. These are very important for primary healthcare assessment, but when coming as a referral from a hematologist, one need not rely on bad scores to guide further testing. The advantage of bad scores is that they have a very high negative predictive value. So a low bad score virtually excludes a significant bleeding disorder. But the disadvantage is that in very young patients, the bleeding history may be completely negative due to lack of adequate hemostatic challenges. In a time-consuming busy OPD, a bad score evaluation may take anything as much as 20 minutes, which is really a big challenge. So it needs to be abbreviated and may not be possible each time. And the bad score is dynamic. It changes over time. With the next bleed that the individual has, the bad score may increase. So what are the baseline investigations that one needs to do in a case of bleeding disorder? The CBC is a must, because the hemoglobin would give us a degree of the blood loss, how severe is the bleeding disorder. And also it's very important if somebody wants to use platelet function analyzer, because a low hemoglobin would compromise the testing. The TLC and DLC may give us an idea of the presence of abnormal cells like blasts and promyelocytes, which may explain the reason for bleeding. The platelet count reveals a thrombocytopenia, which could be the cause of bleeding. LFT must be done because the liver is the source of all coagulation factors other than factor 8. Hence, an abnormal LFT would be expected to have a variety of deficiencies of different type of coagulation factors. So it's a good thing to have the LFT before you embark on advanced coagulation testing. The preliminary coagulation screen comprises of these tests: the prothrombin time, the activated partial thromboplastin time, the fibrinogen assay, the thrombin time, the platelet count, and the bleeding time, or an alternative method to that is the assessment by a platelet function analyzer. The last test is not so commonly done because the bleeding time lacks standardization. It's difficult to do and is very observer dependent. And the platelet function analyzer is not very sensitive. Neither is it very specific, and it's an expensive equipment to have and not readily available, at least in our country. Pre-analytical variables are very, very important in coagulation testing, but because we must remember that most coagulation tests are functional tests. So we are looking at coagulation proteins, which are enzymes, and they work best at a controlled temperature and pH. So the result of whatever testing we do in the lab will depend actually on the disease that the individual has, the way the sample was collected and handled, and the way we did the test in the lab. So in the lab, we can control our machines, that is the analytical phase, but we have no control on the way the sample was collected or handled till it reached the lab. And most of the pre-analytical, most of the errors in coagulation testing occur in the pre-analytical phase. So I would like to spend a couple of minutes emphasizing sample collection. The patient should have rested, and though fasting is not really required other than for platelet function testing, we usually need a venous sample. This should be a free-flowing sample with a tourniquet applied for a very short time. And if we plan to collect from an indwelling line, then the sample needs to be given 5 saline flushes, and 1 volume which is present in the tube needs to be discarded. Now the sample has to be collected in a 3.2% sodium citrate vacuum tube, and no other anticoagulant is required or is recommended. It has to be only sodium citrate. If we are using multiple tubes, then the EDTA or activator containing tubes must follow the citrate sample and never precede it. Plastic syringe collection is the recommended method, and the tube of the vacuum tube should be also of plastic. The needle gauge should not be finer than 21 G so as to avoid hemolysis, and the blood to anticoagulant ratio is almost sacrosanct. It is 9:1. So if we are planning to take 2.7 ml of blood, there should be 0.3 ml of anticoagulant present in the tube. In children who have high PCV, neonates that is, or in people with burns or cardiac disorders, we need to ensure that the citrate is not in high quantity for the small amount of plasma present in these samples, because that would lead to a fallacious prolongation of the clotting time and lead to further reflex testing. So there is a formula which can be applied to this, which tells us how much citrate needs to be added to the tube, or even a rough guide which tells us that if the PCV is between 60 to 80%, how much of citrate we need for how much of blood. Obviously, this has to be done before the citrate sample is collected. Now, if the sample is collected in the wrong tube, it can have disastrous effects on the coagulation testing. A sample collected in EDTA will result in a prolonged PT, APTT, and a reduced factor 5 and factor 8, and would give us an inhibitor pattern on advanced coagulation testing. And if this is very difficult to pick up unless the primary tube as the EDTA tube is visible, I have seen instances where the sample was collected in EDTA and then shifted off into the citrate tube because it was realized that the sample needs to go in citrate. However, there was already EDTA in the sample. So if it is suspected, then measuring the sodium and potassium of the sample will give us a clue, because that is likely to be very high in EDTA samples. Collection in a heparin tube heparin is a natural anticoagulant, so it acts like an inhibitor. This will give us an inhibitor pattern on all our testing, and we would get a false positive test for LA or for factor inhibitors. Presence of heparin can be confirmed by thrombin time, which is usually prolonged, or by doing a heparin assay, which is a more expensive option. And to neutralize heparin present in the sample, there are heparin neutralizers available. If the sample is collected in a plain tube, of course, the clot is already formed, and serum is what we will be testing, so the fibrinogen will be very low. So when we draw the sample, it's important to remember that the sample has to be taken up to the given mark. There should be no forced pushing into the vacuum tube to avoid hemolysis and platelet activation. About 10% over or under filling of the tube is allowed, but if it's more than that, we need to reject, because then the citrate is out of proportion to the amount of blood present. The tube must be mixed by gentle inversion 3 to 4 times. There should be no vigorous shaking, because this leads to formation of bubbles, which may interfere with the visualization of the clot by the optics of our coagulometer machines. And if somehow the sample is not enough and we try to transfer one half-filled tube to another, that is not permissible, because that doubles the amount of anticoagulant present in the sample. So as you can see, one has to be very rigid in collection of samples for coagulation testing. Sometimes using a very thin bore needle for drawing samples to avoid pain to the patient may lead to hemolysis. And this is what happened in one of our collections when a new phlebotomist used a very thin needle and all samples were hemolyzed. So they have this reddish color in the plasma. Sometimes you may see a partial clot in the sample. We can see it here at the top of the tube. This usually occurs due to slow filling of the tube. And sometimes when there is difficult sampling in children, or if the mixing has not been done adequately, this results in a loss of factor 2, 5, and 8, and may give us a falsely high factor 7. If you see any kind of clot on a naked eye examination before testing, this sample has to be rejected. So now let's come to the testing. So the first test is the platelet count. Low platelet counts usually manifest as petechiae and mucocutaneous bleeds. And we say there is thrombocytopenia when the platelet count is less than 100,000 per liter. In a patient who has very severe thrombocytopenia, that is platelet count less than 10,000, a bleed is sort of expected. But patients with the platelet counts more than 100 into 10 to the power 9 per liter are unlikely to bleed. So if such a patient who has no comorbid illness has significant bleeding and a normal screening test, then we need to think of a platelet function disorder. Mostly coagulation factor defects have normal platelet counts, except for von Willebrand disease type 2B, where there is thrombocytopenia and large platelets. When we look at the platelets, it's important to even look at the morphology and the size, because small platelets are associated with Biscott-Aldrich syndrome, which may be associated with skin bleeds, dermatitis, and abnormal immunoglobulin levels. Whereas large platelets with a mean platelet volume of more than 11 femtoliter may be associated with syndromic bleeding disorders, such as the May-Heglin anomaly, the Epstein syndrome, and the Sebastian syndrome. And here there may be inclusions in the neutrophils. Patients with these macrothrombocytopenias, it's important to ask for a history of early onset nephrotic syndrome, nephritic syndrome, or cataract, because these may be clues to the presence of this May-Heglin anomaly syndrome. So now let's go to the coagulation tests. The basic aim of the clotting is to convert soluble fibrinogen into insoluble fibrin. And this insoluble fibrin is then either visualized by our optic coagulometers or is sensed as by the mechanical coagulometers. So the net result is to generate a fibrin clot. And this is done by the action of thrombin, the master molecule of the coagulation cascade. Now, how is thrombin generated? At the site of tissue injury, there is exposure of tissue factor, and this tissue factor, along with the phospholipid, combines with factor 7 to activate it to factor 7A and forms the 7A tissue factor complex. Now, in the patient sample, we add tissue factor and calcium as the reagent, and 7 is supposed to be present in the patient sample. This 7A tissue factor complex forms the extrinsic 10As, which acts on factor 10 to convert it into activated factor 10A, which binds with factor 5, calcium, and phospholipid, and converts prothrombin to thrombin. This pathway can be tested by the PT test, and as we can see, it is heavily relying on the levels of factor 7. The extrinsic 10As is far weaker than the intrinsic 10As, and the factor 7A and tissue factor complex have another role of activating factor 9. Factor 9 gets activated to factor 9A in the presence of factor 8, which is a cofactor, and phospholipid. This activates factor 10 to 10A. This is the intrinsic 10As, which is now activating factor 10. And thereafter, they go into the common pathway to generate fibrin polymer. Factor 9A, on the other hand, can also be activated by contact factors. That is, factor 12 gets activated to 12A in the presence of high molecular weight kininogen and prekallikrein. This activates factor 11 to 11A, and 11A acts on 9 to convert it into 9A. So in the end, we have thrombin generated, which converts fibrinogen to fibrin. So the APTT pathway, APTT test looks at the intrinsic pathway, so it can pick up virtually deficiencies in all. It would have prolongation due to deficiencies in all these factors other than factor 7, which is present in the extrinsic pathway. The thrombin test just looks at the conversion of fibrinogen into fibrin, and with that we can now go to the various screening tests and the combinations that may occur with these tests. So we might see either an isolated PT prolongation. This is likely to happen in the presence of liver disease with oral anticoagulant therapy, vitamin K deficiency, or due to deficiency of factor 7 or presence of a factor 7 inhibitor. If we see an isolated APTT prolongation, the likelihood is that we are dealing with a factor 8, 9, or 11 deficiency, or a severe von Willebrand disease, or the patient has been exposed to heparin as a part of therapy or as a contaminant in the tubing. Lupus anticoagulant, factor 12, prekallikrein and high molecular weight kininogen deficiencies can also produce a prolongation in the APTT. But with LA, there is no bleeding manifestation, and so also with factor 12 and these other contact factor deficiencies. If both PT and APTT are prolonged, then we are looking at a liver disease, or there may be a vitamin K deficiency, or there may be a common pathway deficiency, fibrinogen deficiency, factor 2, 5, or 10 deficiency, and a combined factor 5 or an 8 deficiency. Any of these could be there. If we look at both PT and APTT prolonged with thrombocytopenia, then a systemic disorder is more likely, like a liver disease or a DIC. And if we are looking at a situation where all these tests are normal, then we need to think about von Willebrand disease, factor 13 deficiency, vascular disorders, platelet function defects, and fibrinolytic defects. So let's see with the help of cases how these can be worked out. So in the case of an isolated APTT prolongation, let's look at a patient. There was a 5-year-old male who came with bluish patches on the arms and legs on minor trauma. There was joint swelling of the right knee since 2 years of age. There was no history of any transfusion, and he had 2 siblings who were normal. On the investigations, the APTT was prolonged. So now we are thinking of these possibilities, factor 8, 9, or 11 deficiency, or an inhibitor, and a lupus anticoagulant, or heparin. These were the list which we saw initially. But because there is bleeding, LA is excluded, and there's no history of heparin. So now we have to differentiate between a factor deficiency and an inhibitor. And to do this, we do what is called a mixing test, where we add equal volume of normal pooled plasma to the patient's plasma. Normal pooled plasma is a source of all coagulation factors, so the prolongation in the patient's clotting time will get normalized if there is a factor deficiency due to that factor being provided by the normal pooled plasma. So in this patient, his prolonged APTT was corrected on adding normal pooled plasma. It becomes the same as the normal. So this is a correction, and this is suggestive of a factor deficiency. So the next thing we have to decide is which of the factors 8, 9, or 11 is responsible for this. So we do this by adding a factor, trying the mixing test with a factor deficient plasma. So instead of normal pooled plasma, now we use a factor 8 deficient plasma or a factor 9 deficient plasma and add it to the patient's plasma. If both the patient's plasma and the factor 8 deficient plasma are deficient in the same factor, then the clotting time cannot correct. So if this patient has a factor 8 deficiency with factor 8 deficient plasma, there will be no correction. Whereas if he has factor 8 deficiency, addition of factor 9 deficient plasma will lead to correction. So in this case, this is suggestive of a factor 8 deficiency. The next thing to do is to confirm with a factor 8 assay, which was less than 1% in this individual. So this patient has a hemophilia A. In this patient, we would like to do a von Willebrand factor antigen assay and a ristocetin cofactor assay, especially if the family of this child is incomplete. Because for further pregnancies, we may need to do carrier screening and antenatal counseling, and we need to be very sure that we exclude a severe von Willebrand disease in these individuals. Okay, coming to the second case. Now, this is a 65-year-old male who presented with bluish patches on the lower half of the abdomen. He had no history of bleeding following a surgery for an open reduction of a fracture of the tibia 10 years back. So it didn't look like an inherited factor deficiency. There was no history of previous blood transfusions or a family history of a bleeding disorder. So this looked like a late onset bleeding disorder of sudden onset and somewhat spontaneous. So investigations in him also revealed a prolonged APTT. So now again, we are looking at the same panel. And here again, since there's bleeding, LA is out, there's no history of heparin, so we have to differentiate between a factor deficiency and an inhibitor. Now in this patient, on adding normal pooled plasma, we see that the clotting time of the APTT is not coming back to normal. So this is suggestive of an inhibitor. When we have an inhibitor, the next thing we have to decide is whether it is an immediate acting inhibitor like lupus anticoagulant or factor 9 inhibitor, or it is a time-dependent inhibitor like factor 8. So for that, we repeat the mixing study by incubating the mixture of patient normal pooled plasma for 2 hours and doing an immediate mix as well. So in this, we can see that both of these clotting times have not come back to normal. So there is an inhibitor definitely. And the difference between the start and the incubated mix is more than 8 seconds, which indicates that it is a time-dependent inhibitor. So factor VIII is the commonest type of time-dependent inhibitor that we know. So in this case, we did a factor VIII assay, which was less than 1%. The next thing we need to do, so the likelihood of the possibility in this patient would be the presence of a factor VIII inhibitor, and the likelihood would be that of an acquired hemophilia A, because this looks like a recent onset bleed. He's undergone a surgical challenge without significant bleed in the past. The further test that we would need to do in such a situation would be a Bethesda assay to confirm the inhibitor titer and decide the modality of treatment. Now, if there is an isolated PT prolongation, let's see what would happen. There is a 7-day-old boy who was brought with lethargy and poor sucking. He was born of a normal vaginal delivery. At imaging studies, it was seen that he had bilateral intraventricular hemorrhage. There was no family history of bleeding or consanguinity. And in this patient, the PT was markedly prolonged. The other tests were normal. So now with the PT prolongation, these are the common possibilities that we should consider. There's no history of any oral anticoagulant therapy. So now we need to differentiate between a factor VII deficiency and a factor VII inhibitor. So now we do a mixing study on the PT, and we can see here that on mixing with normal pooled plasma, the PT comes back to normal range. So this patient has a factor deficiency. And when we try to repeat the PT correction with factor VII deficient plasma, we see that there is no correction suggesting that both the patient's plasma and the factor VII deficient plasma are deficient in the same factor, which is factor VII. So this is now suggestive of a factor VII deficiency. This was confirmed on a factor VII assay. And factor VII deficiency is a rare bleeding disorder, but amongst the rare bleeding disorders, this seems to be the most common one encountered. It has a very wide variation in presentation. It may range from asymptomatic to very severe intracranial hemorrhage, like happened in this child. But most of our patients we see are being investigated for other things and are found to have a prolonged APTT, and then we find that they have a factor VII deficiency, which is asymptomatic. There is a complete lack of correlation between factor levels and the severity of bleeding or the age at presentation. In hemophilia, low factor VIII is associated with severe bleeding, but in the rare bleeding disorders and like factor VII, low factor VII levels may not be always associated with very severe bleeding or early presentation. A female child presented with bleeding from the umbilical stump from day 3. She was otherwise healthy. There was history of an elder sibling death in the family with bleeding, but she had 2 other siblings who were alive and healthy. Prior to coming to our center, coagulation tests done revealed a prolonged PT and APTT. Her liver function tests were normal, and she had received vitamin K injections at the center where she was being investigated, but there was no improvement. So she was sent to this place, and we, considering this history, DIC is out because the child is relatively well preserved. The liver function tests were normal, and the vitamin K deficiency was excluded because the vitamin K injections had been given. So now we had to look at a fibrinogen deficiency versus a common pathway factor deficiency. So the next thing to do would be to do the PT and APTT, and here we see that both the PT and APTT are markedly prolonged. In this situation, it helps to do a thrombin time, because if the thrombin time is prolonged, then we are looking at a deficiency in fibrinogen. And sure enough, in this patient, the fibrinogen was virtually unmeasurable. So this was repeated again after 1 month on a fresh sample, and it was low. So this patient had afibrinogenemia. In patients with factor 2, 5, and 10 deficiency, the thrombin time is usually not prolonged. The other causes of prolongation of PT and APTT I have already mentioned before when we were seeing the initial slides. Now let's look at another child. This was a 16-year-old girl who was referred with heavy menstrual bleeding since the onset of menarche 2 years back. She had history of bleeding following a dental extraction 4 years back, and there was history of an uneventful appendicectomy also 5 years back. This history was not very clear, but she seemed to deny history of any blood given at that time or any plasma. Her thyroid functions and hormonal profile was normal. There was no family history of bleeding. And when she came to us, she was on tranexamic acid and had received a fresh frozen plasma transfusion 10 days back. In her, the initial investigations revealed a prolongation of both PT and APTT with a normal fibrinogen. So now these are the possibilities we know that we have when we have PT and APTT prolongation. Liver disease was out, vitamin K deficiency was out, fibrinogen deficiency was out. So now we have to look at these possibilities, a defect in the common pathway. So in her, we did a mixing study on both the PT and APTT, and it showed correction with normal plasma. Both tests were corrected. Then we repeated the correction study with factor 2 and factor 5 and factor 10 deficient plasma. And we can see that on adding factor 10 deficient plasma, there was no correction in either the PT or the APTT. So this is suggestive of a factor 10 deficiency, which was confirmed on a factor 10 assay. And here I must point out that though in these examples, the correction looks very clean and easy, sometimes it is not so clear cut, and one may have to straight away embark on factor assays to reach the correct diagnosis. In fact, some authors say that it is better to do factor assay straight off if there's a high suspicion of an inherited bleeding disorder. Factor 10 is also a rare bleeding disorder with the same findings which I have already discussed in factor 7 deficiency in terms of its lack of correlation with the factor levels and bleeding, and the time of presentation and severity of bleed. A 12-year-old boy came with ecchymosis and epistaxis since the age of 2 years. He had a positive family history. His grandmother had epistaxis. The PT, APTT, and fibrinogen were normal. So now this is the group of disorders we need to investigate. So amongst these, von Willebrand disease is the most common. So we usually start with doing a von Willebrand factor antigen and an activity assay. The GP1BR is a latex immunoassay which looks at the ristocytin cofactor binding assay, but on a coagulometer. And in this patient, both the antigen and activity were reduced. So if the antigen or activity are less than 30%, we are looking at a von Willebrand disease. So that is what this child has. Von Willebrand disease is of various types, type 1, type 2, and type 3. Amongst these, type 1 and type 3 are quantitative defects, whereas type 2 is a qualitative defect. Type 3 is usually easy to diagnose because it has a severe presentation and there is the antigen and activity levels are virtually unmeasurable. To differentiate between type 1 and type 2 von Willebrand disease, we need to calculate a ratio of the activity to antigen. So in this case, the activity is 90, the antigen is 20, so the ratio is 0.9. And if this ratio is more than 0.7, which means both the activity and antigen are proportionately reduced, then that indicates a type 1 deficiency. Whereas if the activity is more decreased as compared to the antigen, that indicates a type 2 von Willebrand disease. If we make a diagnosis of a type 2 von Willebrand disease, then we need to see which one of them it is, 2A, 2B, 2M, or N. So for 2B, this type of von Willebrand disease is characterized by increased aggregation at low dose of ristocytin. So we do a ristocytin-induced platelet aggregation, which will show up this type 2B. In type 2N, the von Willebrand factor is unable to bind to factor 8. So this can be picked up by the von Willebrand factor 8 binding assay. To differentiate between type 2A and 2M, A meaning the loss of high molecular weight multimers of von Willebrand factor, and 2M meaning that the multimers are not absent, but they are sort of not functional. Both of them will show a reduced ability to bind to platelets. These can be distinguished by multimer analysis. So in our patient, there was a type 1 von Willebrand disease. Now let's come to the next patient. This is a 32-year-old female with recurrent ecchymosis and one episode of hematuria. She had a cesarean delivery 5 years back, which was uneventful. The clinical suspicion was that of a von Willebrand disease. Her investigations revealed a normal screen and the von Willebrand panel was also normal. So now the next disorder that we can investigate for easily in our labs is factor 13 deficiency. So for factor 13 deficiency, we put up the urea clot solubility test. Here, the patient's plasma is clotted with either thrombin or calcium. And if the patient has adequate amount of factor 13, the clot remains stable and intact when exposed to powerful denaturing agent like 5 molar urea. In patients who have factor 13 deficiency, the cross-linking of the fibrin polymers is very weak. So on adding 5 molar urea, the clot disintegrates. So the patient's sample is clotted and then incubated along with 5 molar urea for overnight, and the next morning we look at the clot. In a normal person, the clot is well seen, but in a patient with the factor 13 deficiency, the clot completely dissolves. So this patient had a positive urea clot solubility test. This needs to be confirmed, and this was done by measuring the factor 13A antigen, which was less than 3.8%. So we are looking at a factor 13 deficiency in this patient. Factor 13 deficiency can be inherited or acquired. Urea clot solubility test, though easy to do and very easily affordable, is not a very good screening test because it has very poor sensitivity. It will be positive only when the factor 13 levels are very low. So, and is also affected by low fibrinogen levels. So if there is low fibrinogen, the test may give us a false positive. So it is always recommended that factor 13 activity assays be done as first-line tests. This is easily said, but these tests are usually not easily available on our coagulation analyzers, except one odd test for this. So most of us rely on the factor 13 antigen to give us an idea about factor 13 deficiency. The other thing to remember about factor 13 deficiency is that factor 13 is a factor which has a long half-life. It is nearly 10 days. So if the patient has received a recent transfusion, then they may be even though he has basic factor 13 deficiency, the transfused factor 13 may stay for a very long time and hence give rise to a false negative result for testing. So it's always important that if you're suspecting factor 13 deficiency, to call the patient for retesting after at least 1 month of the last transfusion. And the other thing to remember is one must ask for history of abortions and poor wound healing, because these are associated with factor 13 deficiency. A 3-year-old boy was bout with his recurrent bouts of epistaxis. His coagulation screen was normal, the platelet count was normal, the von Willebrand panel was normal, urea clot solubility test was negative. So now in this patient, we need to look for either a platelet function disorder or a fibrinolytic defect. Fibrinolytic defects are relatively rare, so we look for the platelet function defects. Now the platelets, if you remember, are anucleate cells, and but they're very active, and they bear on their surface a large number of receptors. These receptors bind to agonists like ADP, arachidonic acid, collagen, and epinephrine. And when the platelet binds to these receptors, the receptors bind to these agonists, a signal is sent into the platelet, which causes it to degranulate its dense granules and alpha granules and release even more agonists into the circulation, which can stimulate more platelets. So not difficult to understand that if there is a defect in the platelet receptor, it will not be able to bind to the agonist. And if there is a decrease in the number of granules or a defective content of the granules or defective signal transduction to the center of the platelet, then there will be ineffective platelet aggregation. So we can screen for platelet function defects by light transmission aggregometry. Here, what we do is, instead of taking the platelet poor plasma, which we take for routine coagulation testing, we need the platelets. So we take the platelet rich plasma, and to this we add these agonists, collagen, ADP, epinephrine, and arachidonic acid. Then a beam of light is passed through this in the equipment, and as the platelets aggregate, the absorbance of the platelet rich plasma changes. So the light transmission through the sample changes, and this can be measured as a curve on the aggregometer. In functional defects of platelets, the aggregation may be reduced or maybe even absent. So coming back to our patient, when we did light transmission aggregometry, it's very important to remember that always run a normal control, because this test is prone to a lot of pre-analytical variables, as well as has a very high coefficient of variation of testing. So in a normal sample, on adding arachidonic acid, ADP, epinephrine, or collagen, we can see that the platelets aggregate. So there is a nice curve which is formed. In the patient, however, we see no aggregation. So there is absent aggregation with these agonists. We can see it objectively by looking at the amplitude of the curves, which is less than 60% in the patient, so indicating impaired or absent aggregation. With ristocetin, using two concentrations, 0.5 and 1.25 milligram per ml, a normal individual shows aggregation only with 1.25 milligrams per ml of ristocetin. In this patient, there is aggregation at this 1.25 milligrams, but it is much less. So what we are looking at is platelet aggregation responses to ADP, epinephrine, collagen, and arachidonic acid, which are absent. This is suggestive of Glanzmann's thrombasthenia. Now, Glanzmann's thrombasthenia is a platelet receptor defect, but we must remember that the same kind of aggregation pattern we can get in patients with afibrinogenemia. When we do aggregation testing in routine, it's not uncommon to come across abnormalities in aggregation patterns with any one agonist. This is really non-specific, and if we repeat the test, this may even become normal in the second test or on a second sample if we call the patient again for a repeat sample. However, if there's abnormal aggregation with two or more agonists, this is more likely to yield a platelet function defect. So in this patient, where we had suspected a platelet aggregation defect in the form of Glanzmann's thrombasthenia, we took the help of platelet flow cytometry to further confirm our diagnosis. So the platelet-rich plasma is labeled by FITC or PE, which is marking the receptor proteins. The glycoprotein 2B3A receptor is the one which is defective in Glanzmann's thrombasthenia. We can label 2B with CD41 and 3A with CD61. In a normal person's platelets, they are nicely positive for both 61 and 41. Whereas in our patient, we can see that both 41 is absent and CD61 is partially absent. So this is an abnormal pattern which confirms Glanzmann's thrombasthenia. And as I said already, it's a platelet glycoprotein receptor defect. Flow cytometry is useful in detecting Bernard-Soulier syndrome also, another platelet function defect. It can point out defects in platelet activation and secretion from platelet granules. For looking at platelet granule defects, sometimes the light transmission aggregometry may not be abnormal at all, and one may have to rely on electron microscopy. The alpha and delta granules may be either decreased, or their content may be absent, or there may be defective transport of the content to the surface of the platelets. And on flow cytometry, they may manifest as a failure to express the activation markers like P-selectin or CD62 on the surface of platelets, or to bind fibrinogen on flow cytometry. So in this EM photo, we can see some of the platelets show absence of these dark colored granules. Now, fibrinolytic disorders are much rarer and are more difficult to diagnose. The inherited ones are even more rare, and we would like to think of them only when the other ones are excluded. Acquired fibrinolytic disorders are more common. These are seen in severe trauma, with liver disease, with acute promyelocytic leukemia, in carcinoma prostate and other malignancies, and in cardiopulmonary bypass. These are usually the effect as a result of unhindered plasmin activity, leading to lysis of the clot and therefore prolonged bleeding. So this may happen if there is not enough antiplasmin or not enough plasminogen activator inhibitor in the patient sample. These are difficult to test. The test usually done for this is euglobulin clot lysis time. But the other modalities to test are by immunoassays for antiplasmin or plasminogen activator inhibitor, by doing an ELISA or by a chromogenic assay, and some point of care test instruments like the TEG or the TEM may show characteristic patterns indicating a fibrinolytic state. But these are not specific or diagnostic for any of these disorders. So in these situations, one may have to resort to genetic testing. So as you can see, we take a clinical history, there is a clinical examination, then we do a series of tests, and then we do a series of second panel of tests, sometimes a third panel of tests, and use a large number of investigations to reach a diagnosis. So obviously there is something like an algorithmic approach which is being done. And for this, there are a variety of them available, such as this. Some algorithmic approaches for milder bleeding disorders, some algorithmic approaches for children, and others for a whole variety of other bleeding disorders. And in fact, each lab may have to have its own algorithm depending on the kind of population it's looking at and the kind of investigative facilities available. So this is the algorithm that we use in our lab. We usually do the history, CBC, and screen. Then we look if there is a prolonged abnormality of the test, rule out a factor deficiency, look for an inhibitor, see if there is a factor 8 or a 9 inhibitor, and then do a Bethesda assay. If the other tests are normal, then we do a von Willebrand panel or a factor 13 assay and platelet function screening by light transmission aggregometry and flow cytometry. Genetic testing is not required in all bleeding disorders, but if you have a known bleeding disorder like hemophilia A, B, von Willebrand disease, or with rare bleeding disorders, you can characterize the mutation and in the proband, and this may give us some idea about the structure function correlation, may give us an idea about that. But in some bleeding disorders, it is imperative to do a genetic testing before we release the report. One of them is type 2B von Willebrand disease, because the REPA test, which is used to identify this, may produce the same results in a phenotypically similar disorder, the platelet type von Willebrand disease. So to distinguish between the two of them is important because the treatment is different. One needs to confirm by genetic testing. The other situation is type 2N von Willebrand disease, if one does not have access to factor 8 or von Willebrand factor binding assay. It may be required in fibrinolytic disorders or in platelet function disorders where testing is very cumbersome. And it is definitely required where carrier screening and antenatal testing is required. Molecular testing doesn't come free of problems. Sometimes it may reveal unexpected additional bleeding disorders, and we do not know how to explain how much of the bleeding phenotype may be as a result of these. It may throw up a variant of uncertain significance where, again, at a crossroad, how much importance to give it in terms of why it has caused bleeding in a particular individual. Whenever a novel variant is found, we need to do validation studies. And despite all extensive testing and genetic testing, we may never be able to find the cause of bleeding in nearly 40% of our patients. So a good approach to a bleeding disorder would need a combination of clinical examination as well as lab tests. History can guide testing, especially in precious samples of children and neonates with bleeding, where a restricted panel can then be applied. We must remember that acquired bleeding disorders are much commoner and they must be excluded by history to avoid unnecessary testing. Pre-analytical variables can completely throw our tests out of control, and hence we must be aware of these and ensure that samples are well collected and correctly run. Any abnormal test which is not fitting the kind of bleeding we expect or the kind of diagnosis we are expecting, we must repeat it to be sure. Screening tests usually reveal a pattern which can be worked up in an algorithmic fashion. And as we can see, we often need a wide variety of tests to reach the correct diagnosis, and genetic testing may be required for confirmation of diagnosis or for antenatal testing. Learning is usually a combined effort. And I'm very happy to acknowledge the support I receive from my lab for all the testing they do and the number of times we make mistakes and learn from our mistakes to improve our testing abilities. Our clinical colleagues who keep sending us patients from whom we can learn, and our residents who help us by taking a very meticulous history and following up these patients so that we can study them over a period of time. With that, I'd like to thank you for your patient hearing, and I'd be happy to take any questions.
Thank you, ma'am, for this lucid and elaborate talk on approach to bleeding disorders. The case studies were really beautiful, and I'm sure they helped make this difficult topic, much easier to understand for our students in the participant list. We have some questions for you, ma'am. There's a question from Jyoti. Madam, what tests do you do when acquired von Willebrand disease is suspected?
So for acquired von Willebrand disease, the most important thing is to ask for a proper history, because most of them are associated with a characteristic clinical setting. They may be associated with myeloproliferative neoplasms. They may be associated with aortic stenosis and other valvular defects. They may be associated with the monoclonal gammopathies and and hypothyroidism. That may be a common cause. So first thing is to get that out of the way. The rest of the tests that we do are the usual panel for von Willebrand disease. That is the von Willebrand factor antigen, the ristocetin cofactor activity by the GP1BR, and the collagen binding assay. That said, some of the acquired von Willebrand disease may have normal levels of these, and there one may need to do multimer analysis. This is not easily available, and we are also not able to do it. In some patients who have inhibitors, one might modify the GP1BR assay to do a kind of a Bethesda with using normal plasma. I hope that answers your question.
Thank you, ma'am. There's a request from Savitri Singh to please put some light on case 2, which was acquired hemophilia in a 60-year-old patient.
I'm not sure what kind of query you have, but yes. So acquired hemophilia may form 10% of all the hemophiliacs that we look at. Not very commonly seen in our hospital as compared to the inherited ones, because we seem to have a good load from the pediatric side where acquired hemophilia is not really common. The usual thing is the patient, the usual settings are in autoimmune disorders. So that is very important to get history of that if the individual has any kind of autoimmune disorder. The other setting is post-pregnancy, in the postpartum state. That is where there may be an antibody generated against factor VIII and may give rise to an acquired hemophilia. So we need to get that history there. These patients will have bleeding with very low factor levels, but they usually never have hemarthrosis. This is also a very interesting thing. And the other thing that we can pay attention to is that acquired hemophilia can occur in females also. Whereas the usual hemophilia that we are usually looking at, the inherited hemophilia, comes in males, acquired can occur in females also. They usually come with cutaneous bleeds or deep muscle bleeds, and they may be very severe and very disturbing when we look at them. And of course, in the screening, we get a prolonged APTT, which does not show correction with the normal pooled plasma, suggesting an inhibitor. And if it is a time-dependent inhibitor, then the likely diagnosis is usually a factor VIII deficiency, a factor VIII inhibitor. So then we do a factor assay of factor VIII, confirm that it's a factor VIII deficiency. And then after that, we need to fix the titer of the inhibitor so that you can take a call on what kind of therapy you need to do. In acquired hemophilia, usually people are given immunomodulatory or immunosuppressive agents because one has to get rid of the antibody against factor VIII. But if there is an inhibitor in an inherited thrombophilia who has been receiving replacement therapy, then depending on the inhibitor titer, there may be a call to do immune tolerance induction or to do a bypass therapy. So that kind of thing can be done. I don't know if this answers your query.
And I'm sure it does, ma'am. There are some more questions. There are a lot of thank you messages for the wonderful talk that you've taken. There's a question I can't really understand too well. Could you expect any variants of uncertain significance common to all the coagulation phenotypes?
I'm not aware of variants of uncertain significance in this context, because our own experience with the molecular workup of bleeding disorders is still not yet complete. But what we are seeing is the presence of unexpected bleeding disorders. For instance, we have a patient with factor 13 deficiency who has a factor 13 mutation and is heterozygous for von Willebrand factor Normandy. Now, I don't know what that means. Whether it has any bearing here or not, I can't say. And if you get a variant of uncertain significance, it has really no meaning, because until we can validate and show that it has some pathogenic effect, it will just have to remain as a variant of uncertain significance.
Right. So, thanks, ma'am. There's also a small case which Dr. Siaram wants to discuss with you. An adolescent boy with recurrent epistaxis, thrombocytopenia, platelets improve with steroid therapy. Mother also has similar mild thrombocytopenia and hence hereditary platelet disorder and was done for NGS. So NGS was done for that, which showed mutation related to hemophilia A/thrombophilia and gray platelet syndrome. How to interpret this? Quite complicated.
Definitely is. So with a boy, you have a hemophilia. There's a mutation related to hemophilia A. Now, is this, a variant of uncertain significance, or is it actually a pathogenic mutation? And I know of mild hemophilias which will come with epistaxis and things like that, but I don't know of any hemophilia which will come with thrombocytopenia. So if there is a gray platelet syndrome, autosomal recessive, you need to have both mutations, both alleles affected. So I don't know if you just got a heterozygous gray platelet, then mutation, NDL mutation, then I don't know how much significance to give to it. So this is really a very, very puzzling case. Either it's a mild hemophilia. What was the factor VIII level? Was it ever done in this patient?
It's not mentioned in the chat box yet, ma'am. Normal PT and APTT is what Dr. Siaram has mentioned.
So a normal APTT, if you're using a good APTT reagent with good sensitivity, should not miss a factor VIII deficiency of less than 40%, right? But there are some hemophilia mutations or the mild type of hemophilias which we cannot pick up with the factor VIII assay. So there we need to do a chromogenic factor VIII assay and find to actually find out the factor VIII levels, which may show better correlation with the bleeding. So this would be truly a very unusual presentation here. A very, very, I would say it has to be a very mild hemophilia, if at all it is there, to have a normal APTT.
Right, ma'am. So with a history of epistaxis and thrombocytopenia, varying thrombocytopenia, I guess hemophilia would be quite unlikely here. And probably the factor VIII mutation that, or the variant that is there is probably a VUS uncertain significance. And the gray platelet syndrome mutation is probably the one that is causing the problem in both the mother and the child.
So the gray platelet syndrome usually comes as autosomal recessive, which means both genes have to be affected. So then we need to go back to consanguinity and check whether, if the father also has a mutation.
Right. And of course, there's the added complication that there's no bleeding. So the bleeding improves after steroid therapy as well. That is another level of complication that's added to it.
I'm sorry, I don't think I have any answer to explain this really tough case. And hats off to you who are managing it in this way.
So,
sir, can I allow Dr. Siaram to talk, if ma'am permits?
Yes, please go ahead.
Just a moment. Dr. Siaram, you are mute. You can talk to ma'am.
Yes, good evening, ma'am.
Hello, Dr. Siaram. Thank you for sharing this really, really tough case.
Yes. This is of APC route, ma'am. Hello?
Yes.
Yes. This is come from the APC route, ma'am. Advanced Pediatric Center route.
Okay.
I am the MD and SRC both from there.
Okay.
So this case is, ma'am, adolescent boy come with recurrent epistaxis with family history of mother also having borderline platelet between 50,000 to 1 lakh.
Yes.
And lowest platelet is 2,000 only. So,
okay.
So we have done also bone marrow, which have some megakaryocyte. We suspect it may be platelet hereditary platelet disorder, but in view of low platelet, we cannot do platelet count, and we tried steroid therapy. I have reviewed the literature. Sometime maybe add on thrombocytopenia because hereditary is so much low platelet unlikely.
Yes.
And then we started on steroid therapy and child from 2,000 to it reached to 3 lakh. And then no bleeding April, and along with APTT, PT twice normal, factor 8, 9, and VWD also normal, ma'am. We have good coagulation lab with Dr. Abhishek Purohit is here.
Yes, I know. So, can you just tell me one thing, that the epistaxis and all, has it settled eventually? Did
Yes,
he
now
have,
settled, no bleeding, ma'am. After steroid therapy.
now it's settled.
Yes, ma'am.
So, most likely what you are looking at is a platelet count problem rather than a platelet function defect. Right?
Yes, ma'am.
And if we are thinking of the gray platelet, that's a platelet function defect more than anything else.
Yes, ma'am. Yes, ma'am.
So I don't think we can just pin down this bleeding disorder to your mutation which you have got on NGS.
Yes, ma'am. So we treat as a functional disorder.
How about an ITP along with this?
Yeah, yes, that is, we think it may be rare combination. Unlikely.
Yes, because there's nothing to stop an ITP occurring in a patient who has any other kind of hematological disorder.
Yes,
I guess.
So I will try mail you summary, ma'am, with detail of them.
And if we say that the mother has a low platelet count, then we have to be careful, because in some parts of India we have constitutional thrombocytopenia.
Okay.
Right? Yes. So say for instance, patients coming from the eastern part like Bengal and the eastern states, they have a low platelet count. So it has no meaning. This may not cause.
We have one case from Bengal, the similar, the syndrome label. I unable to remember the name.
Achha.
Yes, ma'am.
The other thing is to have a look at the, the morphology and all also of the platelets. Are they macrothrombocytopenic, or is there macrothrombocytosis, or are they small platelets?
Platelet size is larger size, ma'am. Yes, platelet size is larger.
Platelets are
larger. Other CBC is normal. We also evaluated the father also. His CBC and everything normal.
Right.
No consanguinity is there.
Right. And the bleeding has occurred over what duration, would you say? Was it present since birth, or is it just a recent event?
Later on, not since birth, ma'am. It occurred during the last 6 months only.
So then I would very much think of an acquired situation. Something has occurred in this period, which has now gone, hopefully.
Yes,
and you may not need to continue, but this can be very misleading if you do genetics and you find something which doesn't explain the situation. Now I don't know what you will do for the hemophilia.
And another is, after transfusion, platelet not improve during the acute thrombocytopenia. So that again go against that favor the ITP, ma'am.
Okay.
Yes, ma'am.
No, but what are you going to do for the hemophilia? It's a variant of uncertain significance, right?
Yes, ma'am. The significance, unknown significance they mention, ma'am. The mutation is.
So then there's precious little we can do now, and just hope that the the factor 8 levels, etc. are normal. So this is not likely to be the cause of bleeding.
Yes, ma'am. Factor 8, we done completely, ma'am. Hemophilia, factor 8, 9, and VWD are normal, and PT, APTT also normal twice. We try to mention twice, ma'am.
Fine.
Okay.
Interesting. But I would still put my bet on some acquired situation in these last 6 months, which is now improving.
Okay, ma'am.
Thank you, Dr. Siaram, for that really interesting case. I think there are no more questions on the chat box, ma'am. Lots and lots of thank yous for the wonderful talk that I've taken.
No, I just like to thank the audience for their attention.
And thank you, ma'am, for such an interactive session.
And thank you, everybody, for listening in. And it's goodbye from here.